Hello and welcome to this recorded lecture of the regional anatomy of the lower extremity. This is Dr. Pasco again, and let's get to it. Let's begin by discussing the functions of the lower extremity. As we go through the anatomy of the lower extremity, I'll be sure to point out that these structures are adapted for the weight-bearing, locomotion, and maintenance of equilibrium purposes that the lower extremity serves. Recall that the lower extremity is part of the appendicular skeleton and is attached to the axial skeleton via the pelvic girdle. We're going to begin our discussion on the lower extremity by defining the pelvic girdle and the bones that comprise the pelvic girdle, but please realize that the lower extremity attaches to the axial skeleton via the pelvic girdle in a similar way as the upper extremity attaches via the shoulder or pectoral girdle. The pelvis is part of the pectoral girdle, and in this anterior view, we can see the components that make up the pelvis. Two innominate bones. Here's the right innominate bone. Sometimes you'll hear it referred to as a coxal bone. The sacrum in the center, and the coccyx, which is extending off the inferior aspect of the sacrum, hiding in this illustration behind the pubic symphysis. So these are the components of the pelvis. Again, which is the way that the lower extremity articulates with the axial skeleton. Now, the pelvic girdle has different anatomy between the two sexes, and I'd like to review those differences with you now. On the right, we have the male pelvis, and on the left, we have the male pelvis. On the right, we have the female pelvis. The subpubic angle of the male is around 70 degrees. And by subpubic angle, I mean this angle here formed by the inferior pubic rami. Compare that with the much larger subpubic angle of the female pelvic girdle, which is around 90 to 100 degrees. Now, the female pelvis will also present with a much greater sacral width, as well as a greater flare of the iliac bones. This would be a very easy way to identify a pelvis as either male or female. Now, the sex differences that exist within the pelvis permeate throughout the lower extremity to account for lower extremity function. So here we have on panel A on the left the wider pelvis of the female compared with the much more narrow pelvis of the male. And the primary difference I'd like you to understand at this point is that the wider pelvis brings the proximal aspect of the femur out more laterally in the body, meaning that in order to keep the feet underneath the body, the female knee has a much greater genu valgum or knock-kneed presentation. And this has all sorts of consequences for muscle activation, muscle development, as well as flexibility and stability. Now, the pelvic girdle contains several joints. The pelvis, or the innominate bone, as it articulates with the sacrum, is known as the sacroiliac joint. The two innominate bones unite anteriorly at the pubic symphysis, and the femur will articulate with the innominate bone at the acetabulum at a joint known as the hip joint. Looking at a lateral view of the right innominate bone, we can recall that this bone consists of three fused individual bones, superior being the ilium, the inferior anterior component being the pubic bone, and the inferior posterior component being the ischium. Now, in this illustration, each bone is color-coded, which helps you understand that the innominate bone is the union and fusing of three individual bones, but also that this union happens centered around the acetabulum. So if we look within the acetabulum, we'll see that common point of union, of ossification, is located within the acetabulum, which does have consequences for acetabular fracture, as this region is prone to fracture during trauma. And to understand how the innominate bone developed, we can look at this radiograph to understand and appreciate that the bones fuse in different stages. first the ischiopubic ramus coming together between ages 7 and 8. So we really don't even see that here. The pubic ramus and the ischial ramus, we don't really see where they've united. So that must mean that this radiograph is of an individual that is older than 8 years old. However, this individual has not reached full fusion of the innominate bone, as we can see by the presence of cartilage between the ilium and ischium, ischium and pubis, pubis and ischium. This space is going to be filled with cartilage that has yet to ossify. Pelvic ligaments are also in place to add to the stability of the sacroiliac joint that we saw in the previous illustration. So the following two ligaments are one of several ligaments that stabilize the SI joint, but these are considered two of the most relevant. The sacrotuberous and sacrospinous ligaments being those two ligaments. Both of these ligaments have attachments on the lateral aspect of the sacrum, but the sacrotuberous ligament extends to the ischial tuberosity, whereas the sacrospinous ligament will extend to the ischial spine. Now, these ligaments are important for SI joint stability, but they also participate in the formation of two large entry points of contents within the pelvis out into the lower extremity. So let's take some time to understand these two foramen, these two openings, and what their borders are. The larger being the greater sciatic foramen. It is superior to the lesser sciatic foramen, and its boundaries are the following: the anterior sacroiliac ligament, the sacrotuberous ligament, sacrospinous ligament, and the greater sciatic notch of the innominate bone. These boundaries all come together to form the greater sciatic foramen. And in a similar fashion, the spine of the ischium, the sacrotuberous ligament, and the tuberosity of the ischium form the lesser sciatic foramen. Now, with these boundaries understood, let's discuss the contents. Beginning with greater sciatic foramen, looking at this posterior view, the greater sciatic foramen will transmit the piriformis. The piriformis muscle attaches to the lateral aspect of the sacrum at its proximal origin and attaches distally onto the greater trochanter of the femur. And so these two attachment sites will cause it to transverse through the greater sciatic foramen. We'll also find that the sciatic nerve is coming out of the greater sciatic foramen, as it is located inferior to the piriformis, along with the posterior femoral cutaneous nerve, superior gluteal vessels, which we can see here, artery and nerve, inferior gluteal vessels, inferior gluteal nerve, arteries and veins, as well as the pudendal nerve here. So these are the neurovascular as well as muscular structures that will be passing through the greater sciatic foramen. The lesser sciatic foramen, being the smaller of the two, will transmit fewer structures. Obturator internus muscle, which we can see the belly here on the internal aspect of the obturator membrane, and its tendon, which leaves the lesser sciatic foramen to extend out to the greater trochanter. We also have internal pudendal vessels, which are passing into the lesser sciatic foramen, as well as the pudendal nerve. Now, the pudendal nerve is listed under both sciatic foramina, as well as the internal pudendal vessels, to demonstrate the course of these structures as they leave the pelvis through the greater sciatic foramen, and then gain access into the ischioanal fossa by passing in through the lesser sciatic foramen. The acetabulum, as mentioned before, participates in the articulation with the head of the femur to form the hip joint. And so the orientation of these two structures at the hip joint need to be reviewed. And so we can find that in this lateral view of the acetabulum, of the innominate bone, I should say, that the acetabulum faces laterally, so as if it's facing out of the screen at you, as well as an anterior and inferior orientation indicated by the red arrow, which means that the accompanying head of the femur will have a medial orientation that is into the acetabulum here, as well as an anterior and superior orientation. And as we look at some detailed features of the acetabulum, we'll find a smooth surface of the bone, which is known as the lunate surface. Now, the lunate surface is incomplete at its inferior aspect. And so in order to close off the full circular aspect of the acetabulum, the transverse acetabular ligament is in place to complete this circle. The transverse acetabular ligament also provides attachment for the ligament of the head of the femur. This is a coronal or frontal section through the hip joint, and it gives us good opportunity to appreciate that it is a synovial joint by definition because it has a joint capsule which is lined with a synovial membrane that secretes synovial fluid within the joint space. And of the 6 types of synovial joint, the hip joint is a ball and socket, also known as a multi-axial joint, which means it has several degrees of motion and lots of movement offered at this joint. So we can really see the depth of the acetabulum as it articulates with the head of the femur. So the ball is the head of the femur and the acetabulum is the socket. And about this joint, we have the following movements that I thought would be good to review with you, just so we're on the same page. These are the movements of the thigh at the hip joint: flexion and extension. Flexion being the anterior movement of the femur, whereas extension would be the posterior movement of the femur. Lateral rotation as well as medial rotation, with lateral rotation shown here and medial rotation depicted here. There's also abduction as well as AD or adduction offered at the hip joint. And I should note that a composite motion combining all of these movements is known as circumduction. Circumduction is defined as describing a cone in space where the base of the cone is described by the foot and the apex of the cone is at the hip joint. So think of circumduction as being a combination movement of flexion, extension, lateral rotation, medial rotation, abduction, and adduction. All of these movements are needed to describe a cone in space at the hip joint. Now let's move to a discussion of mild deformities of the lower extremity. I'd like to show you some photos on the left, beginning with a coxivara and genuvalgum. So we're not going to be able to appreciate the underlying anatomy for the coxivara, but I will tell you that genuvalgum is the medical term for knock-kneed. And I hope that you can appreciate that in this photo of this individual, that their knees are much closer together. This is a genuvalgum. Coxavalga and genuvarum is depicted on the right in these two individuals. And I don't expect you to appreciate what's going on at the hip for coxavalga, but rather that we can appreciate the genuvarum deformity known as bow-legged. Now, I do expect you to associate coxivara with genuvalgum and coxavalga with genuvarum. These two deformities of the lower extremity go together, and it's just much easier to appreciate the deformity at the knee compared with at the hip. But we'll take some time to understand what is going on with coxivara and coxavalga. So we need to have a discussion about the underlying anatomy that accounts for these presentations. So to understand these mild deformities, let's begin with the definition of the angle of inclination. Now, this is a measurement of the proximal aspect of the femur that is not always appreciated from the surface view. So I'll give you the definition of angle of inclination, and then we'll see how it varies individual to individual. This is the normal angle of inclination, which is defined as the angle formed between the axis through the neck and head of the femur and the axis through the shaft of the femur. So typically this angle between these axes is 125 degrees. When that angle is greater than 125 degrees, this is defined as coxa valga. Now, coxa valga, as you may recall, leads to genuvarum, bow-legged. You're not always going to appreciate and be able to see the underlying coxa valga, but a coxa valga will lead to genuvarum. The other consequences of this increased space between the knees when the individual is asked to stand in a relaxed position is that the lower extremity or extremities are lengthened. So we could see that by opening up this angle, increasing it to greater than 125 degrees, that the head of the femur will still fit in the acetabulum, and the rest of the femur will extend more inferiorly, lengthening the extremity overall. The other consequences include increased load on the femoral head and a decreased load on the femoral neck. So now the line of gravity through the femur is becoming much closer through the axis of the head and neck of the femur and the shaft of the femur. So a lot more load will be put upon the head of the neck, whereas the neck of the femur will experience a reduction in loading. The opposite situation is also possible. Coxa vera is going to be the underlying anatomy that can account for the mild deformity of genuvalgum, known as knock-kneed. Now, the overall effect as well of coxa vera is a shortening of the lower extremity, and in terms of loading, we won't see as much loading on the femoral head, but we will experience a greater loading on the femoral neck, as the shaft of the femur is now located much more laterally and away from the center of gravity of the body. Now, the reason why we care about the loading of the head and neck of the femur, with a coxa valga situation, there will be much more loading on the femoral head, increasing that person's risk for development of osteoarthritis at the head of the femur. Compared with an increased load on the femoral neck, this would put this individual at a greater risk for a fracture through the neck of the femur. Now, the angle of inclination also leads into a discussion of the quadriceps angle. And we like to abbreviate quadriceps angle as Q angle. No need to say all of that. Q angle will be just fine. And in men, the Q angle is typically 12 degrees. So the Q angle is going to be defined as an angle between the shaft of the femur now and the tibia. So we can see that in men, the Q angle is typically much smaller than in women. And this is a good estimation for the genuvalgum. So we mentioned the sex differences of the pelvis and how these lead to overall differences in function of the lower extremities between men and women. And certainly the degree of genuvalgum is going to play into the biomechanics and the functioning of the lower extremity. So we can just see this in a very clear illustration here that the Q angle of men is less than that of women. So that was our discussion on the genuvarum and genuvalgum deformities of the lower extremity. Let's move on to other common deformities of the lower extremity, shown in the photos here. On the left, the pigeon-toed presentation, as well as the duck feet presentation. So these are deformities of the lower extremity that are realized down at the foot. What underlying anatomy could account for these presentations? It also goes back to a measurement or a developmental orientation of the proximal femur. Now, these mild deformities and these angles of inclination and angles of torsion, these are not describing movements of the head and neck of the femur relative to the rest of the femur. This is a fully matured femur. This is a developed bone that has come into this presentation that will then have consequences downstream. This is not the moving of the head and neck of the femur in the acute time frame along with the shaft of the femur. So, to angle of torsion, to account for pigeon-toed and duck feet. First, let's do what we've done before, define the normal. Define the angle. Angle of torsion will be formed by the following two axes. The axis of the femoral head. We're looking at a superior view of the femur. So the proximal femur is coming out of the screen at you, and this is the axis of the femoral head. Ghosted out, going into the screen, is the distal end of the femur, including the femoral condyles. And that's what this gray line is passing through. The gray line is passing through and parallel with the femoral condyles, making the angle of torsion the measurement between these two axes. And the normal value for angle of torsion is 8 to 15 degrees. And just note that the normal angle of torsion is anterior. Now, we talked about this in previous slides where we were looking at the orientation of the acetabulum and the corresponding head of the femur. So the head and neck of the femur are oriented slightly anterior within the hip joint. But there can be varying degrees of torsion of this femoral head and neck, and they come in either an anteversion or a retroversion presentation. So the panel on the left here is showing that normal 8 to 15 degrees. The panel on the right is going to show the anteversion and retroversion scenarios, with anteversion basically describing the proximal aspect of the head and neck of the femur rotating even more anterior than that 15 degrees. Retroversion would be the head and neck of the femur twisted more posteriorly, so less than 8 degrees, all the way down to 0 in some extreme cases. These are the definitions of anteversion and retroversion. Let's consider the consequences of the anteverted proximal femur. Anteversion again is an increased angle of torsion, greater than 15 degrees. So here we've taken that anteverted hip and we've put the femur into the acetabulum in order that the toes and the feet are pointed straight ahead. This is ideal, but this doesn't fit right for the hip. The head of the femur wants to be in maximal contact with the acetabulum. So the individual is unable to maintain this external rotation to keep the foot straight ahead as we want it to be. So basically what happens is the lower extremity internally rotates so that the primary goal of seating the femoral head in the acetabulum is met. That's what we can see right here. So we want to keep the femur in the acetabulum, and so for this individual, that results in pigeon toes. An anteverted hip accounts for the pigeon-toed presentation. Let's look at the converse situation to really understand this concept. So with a retroverted hip, we're talking about a decreased angle, so an angle of torsion less than 8 degrees. And again, the system would really like to have the toes pointed straight ahead, but this would put the hip in an incongruent situation. So to increase the maximal contact area between the head of the femur and the acetabulum, the lower extremity is laterally rotated, which results in toeing out, or duck feet, if you will. So retroversion is also, for the same reason, accounting for the duck feet presentation of the patient. And remember that the angle of inclination leads to what happens at the knee. So now for the hip joint. Like all synovial joints, it's going to be lined by a synovial membrane, and superficial to that synovial membrane is a fibrous joint capsule. So this is the joint capsule of the hip. You won't be dissecting down this deep, but just appreciate that this fibrous joint capsule is there to add stability to the hip joint. And it does so by thickening into capsular ligaments. So this is an anterior view of the hip joint, and we're going to use this as our starting point for the 3 capsular ligaments of the hip. The primary being the iliofemoral or Y ligament. The iliofemoral ligament is illustrated here with a common attachment, or the stem of the letter Y, at the anterior inferior iliac spine, fanning out along the intertrochanteric line. This is the iliofemoral ligament. It's also known as the Y ligament because it resembles an upside down Y. Now, it's the primary stabilizer of these 3 capsular ligaments that we'll be discussing. It's so strong that it can hold the body weight balanced over the femoral heads. And perhaps you've seen people stand like this, or you've stand like this yourself, where you're leaning back and you're just really extending your hip, and you're putting all of your weight through the front of your hip, putting the iliofemoral ligaments on stretch. We can also see the second of the three capsular ligaments peeking around from the posterior aspect. This is the pubofemoral ligament. So iliofemoral because of its attachment on the iliac bone, pubofemoral for its attachment from the pubis to the femur. And to see the rest of the story of the pubofemoral ligament, we'll go to the posterior aspect to see how it wraps around from the inferior aspect of the pubic bone to the femur. We can also see the iliofemoral ligament's posterior attachment as well, and we can see the third capsular ligament, the ischiofemoral ligament, coming off of the ischium and wrapping out to the femur. All three of these capsular ligaments will limit the hip, and it will limit extension of the hip. Now, this is a little unusual because typically ligaments are placed on different aspects of joints, anterior or posterior, and they have opposing limitations. But for these three capsular ligaments, they are oriented, and their attachment sites give them the ability to limit hip extension. So if you imagine this shaft of the femur extending out of the screen at you, you can imagine the ischiofemoral ligament tightening as well as the iliofemoral ligament. Same with the pubofemoral ligament. Pushing the femur into your computer screen in hip extension would also result in the tightening of the pubofemoral ligament. Another ligament at the hip is the ligament of the femoral head, and we can see that in this coronal cut through a cadaveric specimen right here. Now, the ligament of the femoral head does not offer a supporting role like the other capsular ligaments do. This is an intracapsular ligament, and we'll discuss its function in subsequent slides. But also, this is a good opportunity to, in this cadaveric specimen, to discuss the adaptations of the lower extremity for weight bearing, which includes thickened articular cartilage on the superior aspect of the femoral head. We'll also find the thickest articular cartilage on the lunate surface of the acetabulum at the superior aspect of the acetabulum. These are adaptations of the lower extremity for weight bearing. Back to the ligament of the femoral head, also goes by the name of ligamentum teres if you favor the Latin. So here we can see again some content we've discussed already. The ligament of the head of the femur attaching to the fovea of the femur and to the transverse acetabular ligament, offering no structural support. And this is what the ligament of the femur looks like in an arthroscopic view. So in vivo, in a surgical approach, putting a camera into somebody's hip joint, we can see the head of the femur here, its articular cartilage, lunate surface of acetabulum, and the ligament of the head of the femur here. Now, the ligament of the head of the femur will become disrupted in the case of posterior dislocation. So in our understanding of posterior dislocation, please understand that a posterior dislocation outnumbers an anterior dislocation 9-to-1. This is the most common direction to dislocate the hip. And the most common mechanism for a posterior hip dislocation is illustrated in this top panel as a motor vehicle accident where the distal aspect of the femur is rammed into the dashboard and the hip is flexed, so we're already in a position to push the proximal aspect of the femur, that is the head of the femur, out of the acetabulum. And as it does so, we'll definitely damage the ischiofemoral ligament and the ligamentum teres. But most critically, this neural structure that's located posteriorly to the hip joint, the sciatic nerve. So the relation for the sciatic nerve is between the ischial tuberosity and the greater trochanter. So you can see that if you push the head of the femur into that location, you're definitely at risk of damaging the sciatic nerve. So although the hip dislocation will be reduced in the emergency department, it is also critical that the function of the sciatic nerve in the lower extremity is also assessed. Moving on to the fascia of the lower extremity, the fascia lata is going to be the deep fascia of the thigh. We can see that in this anterior view of the thigh. This is fascia lata, which wraps around the entire circumference of the lower extremity from the hip to the knee. That is the thigh. And we can also consider that the fascia lata is an extension of the inguinal ligament. Okay, so the inguinal ligament is continuous with the fascia lata. It's the same structure, it just changes names now that we are inferior to the location of the inguinal ligament. We're now encircling the thigh. So this is that dense, thick, deep fascia that is just superficial to the muscles of the thigh. Another specialized region of the fascia of the lower extremity is the femoral sheath. So as the vasculature developed and made its way inferior to the inguinal ligament, it brought with it a continuation of iliacus and transversalis fascia. So this is the femoral sheath, this structure right here. It contains the femoral artery and vein, which are defined as beginning inferior to the inguinal ligament. Here's external iliac artery and vein. And as external iliac artery and vein pass posterior to inguinal ligament, they become femoral artery and vein. And they bring with them the fascia of the iliacus muscle as well as the transversalis fascia. This fascia comes down into the thigh as the femoral sheath. We should also appreciate that there is a patent opening in the fascia lata just inferior to the inguinal ligament, and this is the saphenous opening. You will find the saphenous opening in dissection, and its relevance is that it is a major passageway for the superficial drainage of the lower extremity to gain access to the femoral vein. That primarily being through the great saphenous vein draining into the femoral vein. Okay, let's move on to our discussion of the gluteal region. We'll start to go through the various regions of the lower extremity so that way you can lump together muscles and neurovasculature. So we'll first begin this organization of content by looking at the gluteal region, and let's get a sense of the boundaries that demarcate this region. Inferiorly, the gluteal fold will serve as a surface landmark for the inferior border of gluteal region, and that gluteal fold will come out to the greater trochanter and continue laterally as a line that joins up with the anterior superior iliac spine. We then go from the anterior superior iliac spine to follow along the iliac crest down into the midline of the body for the medial border, thus defining the gluteal region. Dissecting through the skin and superficial fascia of the gluteal region, we'll find a specialized fascia known as the gluteal fascia, and the gluteal fascia is continuous with the fascia lata of the thigh. And going deep to the gluteal fascia, we will find muscles of the gluteal region, beginning with the gluteus maximus, which is illustrated here. Functions to extend and laterally rotate the thigh. It is innervated by the inferior gluteal nerve. Cutting and reflecting gluteus maximus will reveal the gluteus medius. If I go back a slide, you can actually see a little bit of gluteus medius peeking out deep to the gluteus maximus. So you can, in dissection, define the superior border of gluteus maximus by blunt dissection, and then you'll be able to see a little bit of gluteus medius as it makes its superior attachment onto the iliac crest. The function of gluteus medius is to abduct and medially rotate the thigh at the hip joint. It is innervated by superior gluteal nerve. And if we dissect and reflect the gluteus medius muscle, we'll find gluteus minimus deep to it. This is also an abductor and medial rotator of the thigh. it is also innervated by the superior gluteal nerve. So the primary hip abductors are the gluteus medius and minimus, and they are innervated by the same nerve, the superior gluteal nerve. And it is a very common clinical presentation for a patient to present with weakened or ineffective gluteus medius and minimus muscles. And that presentation is what is known as a Trendelenburg or gluteal gait. So the basic clinical presentation is that the pelvis tilts away from the affected side. So we'll be able to appreciate that when we look at the normal gait cycle. So in unilateral stance, when weight is put through the lower extremity, the ipsilateral gluteus medius and minimus muscles will be able to resist the gravity pulling the contralateral side of the body down. So these muscles are very much active ipsilaterally during the stance phase of locomotion. If there is a problem, a lesion, let's say, in the superior gluteal nerve, this would result in insufficient or inactive gluteal muscles. And so when the patient is in unilateral stance with the right limb, the pelvis will tilt away to the left side. So away from the right and to the left. The weight of the left side of the body is not able to be counteracted with the activation of the right gluteus medius and maximus. And in extremely chronic situations of long-lasting Trendelenburg gaits, we would actually find that the patient would compensate for the ineffective small gluteals by shifting the center of gravity of the body by leaning the torso to the affected side. So the overall goal for the system is to keep the pelvis level. And we can do this with viable gluteus medius and minimus muscles. However, with compromise to the superior gluteal innervation of these muscles, the pelvis would sag. And so if this persists long enough, the individual may try to keep the pelvis level by shifting the center of gravity to the right with a torso lean to the right. This is known as a Duchenne's limp. So let's pull up a video of Trendelenburg gait to illustrate this mechanism. See if you can tell which is the affected side. As you can see, it's quite a popular video.
Just gonna film you walk if that's okay, just for educational purposes. No.
For educational purposes. Okay, so which side is the pelvis tilting toward? I would say toward the patient's right, which means that the gluteus medius and minimus of the left are impaired. In the gluteal region, in addition to the gluteus maximus and the primary hip abductors, we have several lateral rotators of the hip. I'd like to review these 6 with you now. Here's a posterior view of the hip, and we will find from superior to inferior, these lateral rotators include the piriformis, superior gemellus, obturator internus, inferior gemellus, and the quadratus femoris. Now those are 5 of the 6. In order to see the 6th lateral rotator, we need to remove quadratus femoris, and you'll be doing this in lab. You will reflect quadratus femoris, and then you'll be able to look more anteriorly to find the obturator externus. Obturator externus is the sixth lateral rotator, and it is innervated by the obturator nerve. Now, rotation of the thigh at the hip is what we've just been discussing with these lateral rotators. And whether or not a muscle is an internal or an external rotator, that is lateral or medial rotator, is dependent upon the distal attachment relative to the longitudinal axis of rotation. So bear with me as we look at the situation of the skeletal anatomy of the lower extremity here in this illustration, showing the longitudinal axis of rotation down the center of the head of the femur and the middle of the femoral condyles. The shaft of the femur has an anterior bend to it, or anterior bowing. So this will actually have an effect on whether or not a muscle is an internal or external rotator based on what side of this axis that distal attachment is. So if we look up here, a lot of those muscles we just discussed are attaching onto the greater trochanter. So they are going to be behind the longitudinal axis of rotation, posterior in other words, so they will be lateral or external rotators of the thigh at the hip. If one of those muscles happen to be distally attached anterior to the longitudinal axis of rotation, it would then become an internal rotator. So let's look at some other examples at the lower extremity. In this superior view of the femur, this dot right here is the longitudinal axis. The external rotators are solid, and we just saw a lot of the primary external rotators. Gemellus superior and inferior, piriformis, obturator internus, and quadratus femoris. Obturator externus is technically an external rotator, but it is not going to be a primary external rotator just due to its line of pull. Internal rotators are depicted in this illustration as dashed lines. And they are going to primarily function when the thigh is already laterally rotated. So one muscle that's very confusing and difficult to understand its rotation moment about the thigh is adductor longus. So the muscle of adductor longus, the force is directed anterior to the axis, causing internal rotation. So here's a superior view. Here is that longitudinal axis. Here is adductor longus, and its attachment is onto the shaft of the femur, the posterior aspect of the femur. So when it shortens, it's actually going to perform internal rotation. This is anterior in this situation. Refer to the key here. This is posterior back here. So when adductor longus shortens, it is actually going to cause internal rotation. And that's, again, due to the anterior bowing of the femoral shaft. Now what I'd like to do is summarize the musculature of the compartments of the thigh now that we're done with our description of the gluteal region, and we will be able to attribute muscles of the thigh into one of the following three compartments. Anterior compartment, shown here, posterior compartment, shown here, and medial compartment, shown here. Now, these compartments are defined by different intermuscular septa. The lateral intermuscular septum is going to split the anterior from the posterior compartments of the thigh, whereas the medial intermuscular septum will separate anterior from medial. So think of the intermuscular septa as extensions of the fascia lata of the thigh that come in between the muscles and attach onto the femur. So they're going to form compartments. Within these compartments, we'll find the following muscles. In the anterior compartment, we'll find rectus femoris, vastus medialis, vastus lateralis, vastus intermedius, and sartorius. These muscles are found within the anterior compartment of the thigh, and it's a good idea to keep these muscles together as a group because they have common functions. Flexion of the hip, extension of the knee. They also share innervation by the femoral nerve and blood supply by way of femoral artery. Medial compartment can be viewed here in this medial view of the thigh. The muscles belonging to medial compartment include adductor longus, adductor brevis, adductor magnus, and the gracilis. Their common functions are to adduct and medially rotate the thigh, all innervated by obturator nerve and supplied by obturator artery. Adductor magnus is a little unique in that it has two portions, an adductor part and a hamstrings part. This muscle shares a dual innervation, or has a dual innervation. But fortunately, the adductor portion has innervation corresponding to the adductors of the medial compartment, that is obturator nerve. Function of this part of the muscle is adduction of the hip. The hamstring portion, as we'll see in a moment, has innervation common to that of the other hamstrings or posterior compartment muscles, innervation through the sciatic nerve, specifically the tibial division. This muscle will form to extend the hip, which again is a common feature of the posterior muscles of the thigh. These are those posterior muscles of the thigh, known as the hamstrings, biceps femoris, long and short heads, semimembranosus, and semitendinosus. Their common functions are to extend the hip and flex the knee. They are innervated by the tibial division of the sciatic nerve, and their blood supply is from the profunda femoris artery. There is no lateral compartment of the thigh, but let's study the lateral aspect of the thigh because you will be asked to find certain structures in dissection. There's a thickening of fascia lata on the lateral aspect of the thigh known as the iliotibial tract. You'll also hear this referred to as the iliotibial band. It will have interaction or connection with gluteus maximus and tensor fasciae latae muscle. Those will be the proximal attachments of the iliotibial tract. The distal attachment will be the lateral aspect of the tibia. It's also worth noting the course of these primary peripheral nerves of these compartments of the thigh, beginning with the femoral nerve. Now, the femoral nerve's segmental components are L2, 3, and 4. And just to remind you, that means that these are the spinal nerves that are present within the femoral nerve. Now, the course of the femoral nerve is that it will come off of the lumbar plexus. It will be found in the pelvis, lateral to the psoas major. It will go posterior to the inguinal ligament, where it will then enter the thigh, where it will then branch several times. And these branches will be going out to muscles. Some will also be going to skin as anterior cutaneous nerves, but the saphenous branch is the lone branch that descends through the femoral triangle and enters the adductor canal. This saphenous branch will become a cutaneous branch, providing innervation to the thigh, the skin of the thigh, I should say. Another primary peripheral nerve involved with medial compartment muscles is the obturator nerve, segmental innervation L2, 3, and 4. Its course as is follows. It will emerge inferior to the superior pubic ramus into the thigh, where it will divide into two branches, an anterior and a posterior branch. The anterior branch is located anterior to the adductor brevis muscle. The posterior branch is located posterior to the adductor brevis muscle. So when you're trying to name these two branches, keep in mind they are named in relation to the adductor brevis. Then this muscle will go on to innervate the muscles of the medial compartment, and it will also give a cutaneous branch going to the skin. Sciatic nerve is on the posterior aspect of the thigh. Recall from the posterior dislocation discussion that it is found between ischial tuberosity and greater trochanter. So here's the sciatic nerve. About 2/3 of the way down the thigh, it will split. It will split into a common fibular nerve and a tibial nerve. These two nerves are going to innervate the biceps femoris, but different heads. So common fibular nerve will innervate the short head of biceps femoris, whereas the tibial nerve will innervate the long head. The femoral triangle is a region of the anterior thigh that can be used to discuss certain neurovascular features of the thigh. So let's review the borders and contents of the femoral triangle. Borders include the inguinal ligament, the adductor longus muscle, and the sartorius muscle. These three structures define the femoral triangle. The contents of the femoral triangle include the femoral nerve, artery, and vein, in this stereotypical repeatable relation that the nerve is lateral, the artery is in the middle, and the vein is medial. Nerve, artery, vein. The head and neck of the femur receives its arterial supply in the following way. This is a coronal section through the hip, and we'll see that in development that the head and neck of the femur primarily receive arterial supply by way of obturator artery. This is the acetabular branch of the obturator artery, and it is taking blood to the head and neck of the femur. But then as we mature into adulthood, the primary arterial supply is no longer obturator, but rather the medial circumflex femoral. Okay, this is profunda femoris artery. This is the medial circumflex femoral, bringing blood to the head and neck of the femur. Now, in about 10% of adults, the medial circumflex femoral artery has not overtaken the obturator artery to become the primary blood supply. So the following, which is setting these individuals up for avascular necrosis of the head and neck of the femur, which is basically the dying of the bone tissue from a loss of blood supply, can be caused by dislocation or fracture. This dislocation, as we've just seen with the motor vehicle accident scenario, will interrupt the acetabular branch of the obturator artery, because that acetabular branch of obturator artery is found within the round ligaments of the femur. So with dislocation and rupture of that ligament comes the corresponding loss of blood supply to the head and neck of the femur through the obturator artery. And in adults where the obturator artery is the primary supply, medial circumflex femoral cannot compensate, and avascular necrosis can then develop. And still one of the best known cases of avascular necrosis is Bo Jackson in 1990 suffering a dislocation during a playoff game against the Cincinnati Bengals, in which he dislocated his hip, ruptured his obturator artery, the branch going into the head and neck of the femur, compromising the blood supply. Avascular necrosis did develop. He needed a total hip arthroplasty and never returned to the same functional status as a professional athlete. So let's move on down to the knee now that we've done the hip and we've done the thigh, and let's review the joints that are present at the knee. So although the knee is a region of the body, it is going to comprise three separate joints. The most common joint that we probably think of when we think of the knee is the tibiofemoral joint, proximal tibia on distal femur. But there's also a patellofemoral joint between the patella and the femur, as well as a superior tibiofibular joint, also known as a proximal tibiofibular joint. And these joints allow the following movements of the leg at the knee: flexion and extension. And we need to have a discussion about what happens in flexion of the knee. The femoral condyles do not have similar equal morphology. So by this I mean that the medial epicondyle in this inferior view has a much larger presentation, a much larger area than the lateral epicondyle. So due to the larger medial femoral condyle, as the tibia extends in full extension, it will externally or laterally rotate. So if the femoral condyles were equal in size, the tibia would simply swing out of the screen toward you and not rotate at all. It would be a simple hinge joint. However, the medial epicondyle is much larger. So as the tibia is swinging out, try this as you're sitting in your chair, as you go from a 90-degree flex knee to swing your tibia out under the desk to an extended knee, your tibia will then laterally rotate. Now, this is not easy to appreciate, but basically there is a small degree of lateral rotation because the tibia stays in contact with the medial epicondyle for a much larger extent in full extension. Now, this is something that needs to happen because in order to reach full extension of the knee, we want, again, full congruence, full joint surface contact between the tibia and the femur. And so in order to achieve that full contact, we have the tibia laterally rotating. And we can see that here. This lateral rotation of the tibia is referred to as the screw home mechanism. The tibia is becoming seated in its final position, so it's reaching its home, and as it does so, this is accompanied by a degree of lateral rotation. This offers increased stability to the knee. Now, as we just described, the tibia externally or laterally rotates as the knee reaches full extension. So we do need a mechanism in place to initiate flexion of the knee by internally, medially rotating the tibia on the femur. And that muscle that's providing that mechanism is the popliteus muscle. The popliteus muscle internally or medially rotates the tibia on the femur to allow for initiation of flexion. So you could say that the popliteus unlocks the knee. The screw home mechanism is the mechanism that describes the tibia locking out on the distal aspect of the femur in terminal extension. And so in order to unlock the knee, we need to oppose the screw home mechanism. And if we look at the attachments of the popliteus muscle, which can be viewed here, because of its position posterior to the knee joint, going from lateral condyle to medial proximal tibia, when it shortens, it's going to provide that internal medial rotation, also flexion of the knee, to unlock and initiate flexion of the knee, so that way we can have other muscles come in to complete flexion of the knee. At the patellofemoral joint, we'll find that the posterior surface of the patella is covered with thick hyaline cartilage. This is a cross-section through the knee joint, right through the patellofemoral joint. And we can see that the posterior surface of the patella is covered by thick hyaline cartilage, and that the patella is tracking or sliding within the trochlear groove of the femur. So these are the femoral condyles here, and due to their morphology, they will form a trochlear groove that will allow the patella to slide in and out. And if we look at the posterior aspect of the patella, we'll find it has a smooth articular surface, and this surface is divided into medial and lateral facets. Lateral facet being the larger of the two facets. Another ligament we'll find at the knee is the patellar ligaments, and it's going to be the portion of the knee where the fibrous tissue is extending from the patella down to the tibial tuberosity. So a lot of people will call this the patellar tendon, where the rectus femoris and the quadriceps femoris muscle group is coming into the superior aspect of the patella, and the patellar ligament is referred to as the connection from the patella down to the tibia. So the patellar ligament, due to its position and its attachments, it will resist knee flexion. Bursae at the knee include the suprapatellar bursa. So everything that we see stained here in blue is the bursa of the knee. This is internal to the joint capsule. And the suprapatellar bursa is a special portion of this bursa of the knee capsule that extends superiorly. And it needs to be there because, like all bursae, it's helping to lubricate the movement of the tendon over the bone. In this case, the tendon is the quadriceps tendon over the distal femur. Now, the suprapatellar pouch needs to be there during flexion, but then during extension, the suprapatellar pouch would fall into the joint capsule. And we don't want that to happen, so in order to keep the suprapatellar pouch from falling into the joint capsule, a muscle is attached to its superior aspect, indicated by this red arrow, and that muscle is articularis genu. And when it shortens, it's going to pull the suprapatellar pouch. This will happen when the knee goes into extension so that the suprapatellar pouch does not fall into the joint. Just like the hip, the knee has a fibrous capsule, and the margins of attachment for this fibrous capsule include the femoral condyles as well as the tibial condyles. Now we don't see the tibial condyle margin very well because a inverted U-shaped cut has been made in the joint capsule to flop the patella inferiorly. This just demonstrates that we are now inside the joint space. Just like the patellar ligament, there are several other ligaments around the knee to improve its stability. Let's review the cruciate ligaments. This is a superior view of the tibia. This is lateral because you can see the head of the fibula. And you'll find that the two ligaments, cruciate ligaments, are anterior and posterior. And they are named either anterior or posterior based off of their attachment on the tibia. So here we can see the ACL coming off of the anterior aspect of the tibia, PCL off the posterior. So ACL is actually lateral to the PCL, as these two ligaments do what their name implies. Cruciate is referring to cross, so as these two ligaments leave their tibial attachment to move superiorly toward the femur, they will cross each other, with the ACL being lateral to the PCL. And here we can get a sense of that crossing with an anterior view of the knee with the patella reflected inferiorly. Here we can see ACL and how it is more laterally positioned compared with the PCL. And I've given you the proximal and distal attachments here on the side, but I'm sure you could read those at your own leisure. Same deal with the posterior cruciate ligament, labeled here, located more medially to the ACL. Now these ligaments, like all ligaments, restrict movements, and let's take a moment to discover what motions are restricted by the ACL. ACL is typically going to prevent anterior displacement of the tibia. So in this test of the ligamentous stability of the ACL, the clinician is pulling anteriorly on the proximal tibia. And if the ACL is intact and viable, it will become taut and the tibia will not translate very far anteriorly. But if the ACL is ruptured, there will be a large excursion of the tibia, especially in comparison to the non-involved side. PCL, on the other hand, will prevent posterior displacement of the tibia. And in this intact PCL, we would see that tension would develop in the PCL as the proximal tibia was pushed posteriorly. Other ligaments around the knee include the tibial collateral ligament, also known as the medial collateral ligament. Remember genu valgum? That will be resisted by the tibial collateral ligament. So the tibial collateral ligament is located on the medial aspect of the knee joint. It is closely applied to the joint capsule and the medial meniscus. So injury to the medial collateral ligament will typically result in injury to the medial meniscus, and this injury is typically acquired from a blow to the outside of the knee. So this is a medial view of the knee. So picture the forceful blow coming from behind the knee in this image on the other side of the screen, coming out toward you, blasting into the lateral aspect of the knee, putting tension on the MCL, rupturing it. Here's a cadaveric dissection where the medial collateral ligament has been preserved, labeled as number 1, just to give you a sense of how broad, thin, and flat this medial collateral ligament is, especially in contrast to the ligament on the other side of the knee, the lateral collateral ligament, also known as the fibular collateral ligament. This ligament will resist genu-varus stretch, which is the bow-legged stress at the knee, and it would be injured from a blow to the medial aspect of the knee. So due to the fact that the opposite leg is going to be protecting this leg, it's much more likely for medial collateral ligaments to become injured because the lateral aspect of the knees are exposed. The medial aspects of the knee are typically protected by the other leg, so it's much more rare to have a blow to the inside of the knee causing disruption of the fibular collateral ligament. And again, this dissection of the cadaver with a silver staining to show you the presentation of the fibular collateral ligament. Here, number 8. And so to bring it all together with what we've talked about previously with the mild deformities of the lower extremity, genu valgum depicted here on the left, with the tibial collateral ligament put on excessive stress, so at risk for failure or irritation, and in the genu varum deformity, the lateral collateral ligament being in a position of stress. There's also 2 ligaments on the posterior aspect of the knee offering support. Those are the oblique popliteal and arcuate popliteal ligaments. Oblique popliteal ligament spans the semimembranosus tendon, which is out here, all the way to the joint capsule and lateral femoral condyle here. This is the oblique popliteal ligament. The arcuate popliteal ligament spans from the head of the fibula to the intercondylar area of the femur. These ligaments provide posterior support to the knee. And another level of support to the knee are the following muscles that cross the knee together as a group that attach onto the common tendon of insertion of the pes anserine. So pes anserine is going to stick in your mind as a grouping of 3 muscles, because 3 muscles coming together into a common tendon would remind you of a goose's foot. So the Latin for this is pes anserinus, known as pes anserine or the goose's foot. And those muscles which are included in pes anserine are the sartorius, gracilis, and semitendinosus muscles. These muscles are on the medial aspect of the knee, attaching to the medial aspect of the tibia, offering support to the knee. The knee joint also has fibrocartilaginous shock absorbers placed in between the femur and the tibia, and these are the menisci. This is a superior view of the tibia with both menisci present. These menisci are going to absorb shock, decrease friction, and increase the contact area, much like a labrum would increase the contact area at the shoulder or hip joints. The medial meniscus is much larger than the lateral meniscus, and that makes sense because the medial femoral condyle is much larger than the lateral femoral condyle. The medial meniscus is also approximately shaped like a C, whereas the lateral meniscus almost comes together completely to form the letter O. The medial meniscus is also closely adherent to the medial collateral ligament. You can see this here. So any damage to the medial collateral ligament will usually result in concomitant damage to the medial meniscus. And that injury to the meniscus could present itself in several different ways. So here we see 2 common tears of the medial meniscus, a bucket handle tear and a radial tear of the posterior horn of the medial meniscus. And it used to be, back in the 50s and 60s, that a tear of the meniscus was fixed by a total meniscectomy. And the total meniscectomy involved, as the name implies, the complete removal of the meniscus. Now, this is a bad idea with what we know about now, because removal of the meniscus may lead to increased wear on the articular cartilage. See this little bit of articular cartilage on the medial tibial condyle here. This wear would increase without the presence of the medial meniscus. This would cause an increased chance for development of degenerative joint disease and a near 100% incidence of total knee replacement following a total meniscectomy. So now, instead of completely removing meniscus, it's much more common to use an arthroscopic approach to clean up and debride the damaged tissue. Now, in some cases, you can actually repair the meniscus instead of removing it completely or removing it partially. And this is most successful in the region of the meniscus that has the greatest blood supply. So this is a coronal section through the meniscus. Here we can see the meniscus coming into the joint. This is the femur. This is the tibia. And the blood flow follows a 1/3 rule within the meniscus, with the blood flow being the greatest in the peripheral 1/3, intermediate in the central 1/3, the intermediate 1/3, and least in the central 1/3. So if we have damage to the central aspect of the meniscus, it's not worth trying to repair. Just remove it. It will never heal if repaired. But the peripheral 1/3 is rich in blood supply. You can see that in this histological stain. And so it is much more likely for this peripheral 1/3 to heal if surgically repaired with suture. Another important structure in the leg is the crural interosseous membrane, which is a dense connective tissue that spans the internal margins of the tibia and the fibula. Hello and welcome to the conclusion on this narrated lecture set of slides on the regional anatomy of the lower extremity. In this set, we will now move on to finish the lower extremity discussion by discussing the foot and ankle anatomy. So let's first begin by movements of the foot at the ankle joint, defining specialized movements that occur at this joint nowhere else in the body. Those movements are plantar flexion and dorsiflexion. Plantar flexion can be seen here as the inferior movement of the great toe down to the floor. Dorsiflexion is the opposite motion, where you are basically flexing the ankle by moving the great toe superiorly. Inversion and eversion are also specialized movements of the foot at the ankle joint. Inversion would be as if you were trying to turn your foot inward to look at something you've stepped in on underneath your great toe, whereas eversion would be flipping your foot out to the side to investigate something you stepped in under your fifth digit. Movements of the toes are very similar to that of the fingers, flexion and extension. And believe it or not, you're actually able to ab and adduct your toes, but I would say that it's much more of an active process to abduct the toes. And adduction is typically thought of as relaxing the abducted toes. Not a very functional movement in comparison to the abduction and adduction at the fingers. Here are the joints of the ankle and foot. These include the talocrural joint, which is the anatomical term for the ankle joint. It is the joint that allows motion of dorsi and plantar flexion. The subtalar joint is a joint between the talus and the calcaneus, and it is the joint at which inversion and eversion occur about. There are also tarso-metatarsal joints, as well as metatarsophalangeal joints, as well as interphalangeal joints. In the first digit, the first toe, we'd say the great toe, there is only a single interphalangeal joint, whereas toes 2, 3, 4, and 5 have a distal interphalangeal and proximal interphalangeal joint. And going back to our talocrural joint, this joint includes the talus, which is the tarsal that bears the weight of the rest of the body. So we can think of the talus as being a weight-bearing structure. Looking closer at the interphalangeal joints, we'll find that they consist of the head of one phalanx, articulating to the base of the distal phalanx. So these joints are of a hinge type, and they are responsible for the flexion and extension of the toes. Ankle and foot joint, in terms of the ankle joint, we're going to have stability offered by the crural interosseous membrane and the distal tibiofibular joint. So this is a very rigid syndesmosis at the distal aspect of the tibia. Now the ankle joint is often referred to as the ankle mortis, and that is because of its resemblance to a joint in carpentry, where a three-sided structure fits into a three-sided groove. The three-sided groove at the ankle mortis includes lateral malleolus of fibula and the medial malleolus of the tibia. So this is often described as a mortis joint, and that is in analogy to that type of joint in carpentry. Now, we also have deep fascia of the leg, just like deep fascia of the thigh, but remember, the deep fascia of the thigh is called fascia lata. We now call this the deep fascia of the leg now that we're below the knee. And this deep fascia of the leg also forms compartments, and thickening of the talocrural fascia forms retinacula that we will study down here at the ankle joint. The extensor retinacula fall into two structures. There's a superior extensor retinaculum spanning distal tibia to distal fibula, as well as an inferior extensor retinaculum that has three attachments: the calcaneus, navicular, and medial malleolus. Here we can see the navicular attachment, calcaneus here, and medial malleolus here. So these retinacula are positioned anterior to the ankle joint, and they greatly assist in keeping the tendons of these anterior muscles close to the joint. Other retinacula include fibular retinacula, which are either superior fibular, which we can see here, lateral malleolus to calcaneus, or the inferior fibular retinaculum here, which extends from the inferior extensor retinaculum to the calcaneus. So these two retinacular will be spanning over long tendons of our fibular muscles. This is the way the fascia, the deep fascia of the leg, forms compartments of the leg. In this cross section through the middle of the leg, we can see tibia and fibula and the following compartments: anterior, labeled with a 1, lateral with a 2. There are two posterior compartments: superficial, shown here as 3, and deep, shown here as 4. So what I'd like to do is take you through each one of these compartments and review the muscles, nerve supply, and arterial supply of those muscles as well as their actions. And keep in mind that just like in the thigh, these compartments of the leg are separated by intermuscular septa, which are extensions, in this case, of the crural fascia down to the fibula as well as the tibia. The first compartment is the anterior compartment, consisting of tibialis anterior, extensor hallucis longus, extensor digitorum longus, and fibularis tertius. The motions include dorsiflexion, inversion, and toe extension, and eversion would also be a motion of the anterior compartment if peroneus tertius could be isolated. But fibularis tertius is not able to be independently activated, so we don't really consider eversion as a motion of the anterior compartment. The innervation of these muscles is by deep fibular nerve, and the blood supply by anterior tibial artery. The lateral compartment consists of two muscles, fibularis longus and fibularis brevis. The motions here are eversion and plantar flexion. Eversion because the tendons pass laterally to the the subtalar joint, and plantar flexion because the tendons are posterior to the fibula, therefore posterior to the talocrural joint. Innervation is superficial fibular nerve, and the blood supply is by the fibular artery. The posterior compartment comes in two varieties: superficial, which includes gastrocnemius and soleus, as well as the plantaris. So in this superficial view of the posterior compartment, we can see the lateral and medial heads of gastrocnemius and a little bit of soleus peeking out from the side. Removing the heads of gastrocnemius, we can now see a much larger extent of the soleus muscle as well as the plantaris with its long tendon. Motions here include plantar flexion and knee flexion. Keep in mind that the gastrocnemius and the plantaris cross the knee joint, so they will assist in knee flexion. These muscles are innervated by the tibial nerve and supplied by the posterior tibial artery. And now to the deep posterior compartment. The gastrocnemius has been removed or reflected here, so we can see the superior-most muscle of the posterior deep compartment, the popliteus muscle. We just talked about this muscle in relation to unlocking the knee. And as we remove the soleus, as you will reflect the soleus in dissection, we will then see the other three muscles of the deep posterior compartment: the flexor digitorum longus, flexor hallucis longus, and the tibialis posterior. These muscles are plantar flexors, toe flexors, knee flexors, as well as ankle inverters, innervated by tibial nerve, blood supply by posterior tibial artery. Now, compartment syndrome is a clinical scenario that underlies the tight fascia of the compartments of the leg. So trauma, overuse, hemorrhage, or infection produce edema, which is swelling, or hemorrhage within one of the four compartments that I just mentioned. This is really bad because as this swelling occurs, there's no place for this increased fluid to go. The crural fascia is so dense and thick, and the intermuscular septa are so thick that this fluid will not be able to go anywhere. So as a result, there will be an increase of pressure developed within the compartments that will compress nerves and vessels and compromise their function. So a compressed nerve would result in paresthesia, paralysis, and compressed vessels would result in a lack of oxygen delivery and ultimately avascular necrosis. So very serious consequences if compartment syndrome is not managed properly. And due to its severe acute nature, fasciotomy may be performed in order to spare the extremity. So it's very drastic and saves the limb, and what it involves is an incision in the skin. The actual fascia is removed and the skin is grafted. So this is a photo of a patient that underwent an anterior fasciotomy, and we can see that the fascia was removed, and this wound is healing in waiting for the skin graft to be performed. And it is the anterior compartment that is most commonly involved. So here is a list of the different locations of compartment syndrome and the corresponding patient symptoms that you'll need to be aware of. So in the most common compartment syndrome of anterior compartment syndrome, we would expect weakness in dorsiflexion or toe extension and paresthesia over the dorsum of the foot. And this will be due to the nerves that are located within the anterior compartment and the muscles which are innervated by those nerves, as well as the area of skin that is going to be compromised due to the nerve that is coming out of the anterior compartment. Deep posterior would manifest as weakness in toe flexion and inversion, paresthesia in the plantar aspect. Superficial posterior would manifest as weakness in plantar flexion, dorsolateral foot hypoesthesia. Here's a review of the arterial supply of the leg. As we look at a posterior view, the popliteal artery will be found posterior to the knee joint, and the popliteal artery will divide into an anterior tibial and posterior tibial artery. The anterior tibial recurrent will be a branch off of the anterior tibial as it passes through the interosseous membrane near the proximal tibiofibular joint. The fibular artery is a branch off of the posterior tibial artery, with the fibular artery going out toward the fibula, again providing blood to the lateral compartment of the leg. Common fibular nerve is a major peripheral nerve of the leg, so let's review its course just as we did with the nerves of the thigh. We'll find that the common fibular nerve is a bifurcation of the sciatic nerve, and it approaches the fibularis longus, the proximal aspect of fibularis longus, where it will dive deep to that muscle. This is going to occur at the neck of the fibula, where the nerve will curve laterally, and then split into a deep and superficial fibular nerve. So the superficial fibular nerve will emerge here to provide innervation of the skin over the dorsum of the foot, whereas the deep fibular nerve will go into the anterior compartment of the leg. So here's a zoom in of the deep fibular nerve. It approaches the interosseous membrane. It is between the tibialis anterior and extensor hallucis longus muscles. So to find this nerve in dissection, find those two muscles, spread them apart. You'll also confirm that you've found the deep fibular nerve because it will accompany and descend with the anterior tibial artery. Tibial nerve is on the posterior aspect of the knee. It's the other bifurcation of the sciatic nerve. It will join up with popliteal artery and vein, and it will become continuous with the posterior tibial artery. Typically, the tibial nerve will give off the sural nerve, which is a cutaneous nerve on the posterior aspect of the leg. And then if we follow the tibial nerve all the way down into the medial aspect of the ankle joint at the medial malleolus, this will split into medial and lateral plantar nerves at the foot. Here are some of the ligaments of the ankle. Let's begin by looking at the medial collateral ligament, also commonly known as the deltoid ligament. These are the portions of the deltoid ligament: anterior tibio-talar, a tibio-navicular, a tibio-calcaneal, and a posterior tibio-talar. All four of these portions come together to form a triangular-shaped ligament known as the deltoid ligament. It's going to stabilize the ankle, resisting forced eversion, so lifting the little toe up, and it is much stronger than the corresponding lateral collateral ligaments. So much harder to injure, much more rare to injure the deltoid ligament. Other structures that we can then find layered on top of the deltoid ligament, here's the deltoid ligament here, include the structures that pass through the tarsal tunnel. The tarsal tunnel is formed by the flexor retinaculum, which extends from the distal end of the fibula down to the calcaneus. So this is analogous to the flexor retinaculum at the wrist. Instead of forming the carpal tunnel, we have the tarsal tunnel. And we do have tendons going through the tarsal tunnel, the three tendons of tibialis posterior, flexor digitorum longus, flexor hallucis longus, as well as posterior tibial artery and vein and the tibial nerve. They all pass through the the tarsal tunnel, which is formed by the flexor retinaculum. So in tarsal tunnel syndrome, entrapment and compression of the tibial nerve can be present, resulting from edema and tightness of the ankle involving the synovial sheaths. Synovial sheaths are prone to irritation, and irritation will cause swelling. And this swelling will cause compression within this confined space. So if we have compression of this space, the following symptoms will be present: pain, tingling, numbness in plantar aspect of foot, and weakness of intrinsic muscles, all due to the fact that the tibial nerve is found in the tarsal tunnel. It will split into the medial and lateral plantar nerves, which have a functional role in the cutaneous aspect of the plantar foot and innervation of intrinsic foot muscles. Going to the opposite side of the ankle, we'll find the lateral ligament complex, which will again stabilize the talocrural joint, this time resisting forced inversion, and these ligaments are much weaker. These ligaments are as follows: anterior talofibular, calcaneofibular, posterior talofibular, and lateral talocalcaneal. These are all ligaments that form the lateral ligament complex and resist forced inversion. And so due to the fact that they are much weaker, they are the most compromised ligaments of the ankle. 90% of ankle sprains are of inversion injuries. So it's very rare to have that eversion ankle sprain, very common to have that inversion ankle sprain. And due to the typical inversion motion that happens during an inversion ankle sprain, it's the anterior talofibular ligament that ruptures first. So in the lowest grade ankle sprains, it's just the anterior talofibular ligament that is ruptured. But in much more severe ligament inversion ankle sprains, all of these ligaments will become ruptured. And here's a grading of these ankle sprains. With a progression of severity as we move from grade 1 to 2 to 3. Moving on to the foot, we'll find that the foot is included in having two arches, a transverse arch and a medial longitudinal arch. Those two arches are depicted on this photograph. Discussing the medial longitudinal arch first, we'll find the following structures supporting the foot: the plantar aponeurosis here, the plantar calcaneonavicular ligaments, as well as the tendons of tibialis posterior and flexor hallucis longus. They're all inferior of the foot on this inferior plantar aspect, and they are all adding stability to the medial longitudinal arch. Whereas for the transverse arch, we'll consider the following structures as supporting: fibularis longus, this is the inferior view. This is the primary structure that supports the transverse arch. The inferior aspect of the foot, or the plantar aspect, also has the following ligaments: the plantar calcaneonavicular is known as the spring ligament. This is the long plantar ligament from the calcaneus to the base of the 3rd, 4th, and 5th metatarsal. There is also a short plantar ligament, the plantar calcaneocuboid ligament. It is deep to the long plantar ligament, and so in order to kind of get at a visualization of this ligament, I've included this red line to show you the general orientation of the plantar calcaneocuboid ligament, known as the short plantar ligament. This sagittal section of the foot is to just give you an appreciation of how thick the skin is at the sole of the foot. The skin overlying the heel is the thickest of the body. There's also a very thick amount of superficial fascia to cushion the foot during locomotion. And you will need to dissect through that thick skin and dense superficial fascia to find the plantar aponeurosis. The plantar aponeurosis is also known as the plantar fascia. It's on the plantar surface of the foot, just deep to that superficial fascia. And so you'll spend a great deal of time cleaning this up and observing that the proximal attachment is on the calcaneus, and that as the plantar fascia extends anteriorly, it will fan out, become much broader, with a band of fascia serving each one of the 5 toes. And the plantar fascia is commonly inflamed. Plantar fasciitis, also known as policeman's heel. 2 million Americans per year, about 10% of the U.S. population, will suffer from plantar fasciitis over a course of their lifetime, and it is really simply an inflammation caused by overstretch or overuse. And it is usually confirmed as pain in the presence of palpation of the proximal attachment. So pressing on the patient's medial calcaneal tuberosity, which is the attachment of the plantar fascia, will really set off a large amount of pain in patients that have plantar fasciitis. Most often affecting men in the 40 to 70 year range. Now, heel spurs are commonly associated with plantar fasciitis, but the presence of a heel spur does not necessitate a problem. Heel spurs may be present in many of us listening to this lecture and be asymptomatic. So it's very important to use other tests aside from unnecessary radiography to confirm the presence of plantar fasciitis. So it is not necessarily needed to remove surgically these heel spurs. They may be present and asymptomatic, and a heel spur may not accompany the presence of plantar fasciitis. Now, as we understand and observe the muscles of the foot, we're going to want to associate them as belonging to one of 4 layers of muscles of the foot. So let's go through the layers of muscles of the foot with the most inferior layer first, moving on from there. This first layer of muscles includes flexor digitorum brevis, the abductor hallucis, and the abductor digiti minimi muscles. Flexor digitorum brevis tendon will split upon insertion on the intermediate phalange. This is very much a similar situation as flexor digitorum superficialis in the hand. These muscles are innervated by lateral and medial plantar nerves. Then we can reflect the flexor digitorum brevis to see the muscles of the second layer of the foot, which include quadratus plantae and the 4 lumbricals. The 4 lumbricals of the second layer of the foot arise from flexor digitorum longus. Flexor digitorum longus is not a muscle of the second layer of the foot. It's a muscle of the deep posterior leg, as you'll recall, but it does have an important function as an attachment site for quadratus plantae and the 4 lumbricals of the foot. These muscles are innervated either by the lateral or medial plantar nerves. Now moving deeper to the third layer of muscles, we will find the adductor hallucis, which has an oblique and transverse head, along with flexor hallucis brevis, which has a medial and lateral head, and the flexor digiti minimi brevis. These muscles are innervated by either lateral or medial plantar nerves. And lastly, the fourth layer of muscles, consisting of the 3 plantar interossei and 4 dorsal interossei muscles. Now, these muscles have the role of and adducting the toes, and instead of using the 3rd digit like we did in the hand for the axis of this motion, it is now the 2nd digit of the foot, the 2nd toe, that is used as the axis defining abduction and adduction. So anytime a toe moves toward the 2nd digit, that is adduction, and anytime a toe moves away from the second digit, that is abduction. The dorsal interossei and plantar interossei are innervated by the lateral plantar nerve. Other muscles of the foot include a few on the dorsal aspect, the extensor hallucis brevis, which we can see the muscle belly of here, and the tendon here, and the 3 muscle bellies of extensor digitorum brevis. These muscles are both innervated by the deep fibular nerve. The other nerve supply of the foot includes branches of the tibial nerve. And recall that the tibial nerve arises from the sciatic nerve, and that the tibial nerve will pass through the tarsal tunnel to divide into lateral and medial plantar nerves. The lateral plantar nerve will branch into a superficial and deep branch. And this is important to realize because it is the deep branch that will head down to innervate the deep layers of muscles of the foot. Now, as we follow the superficial lateral plantar and the medial plantar nerves out, we will find that they will branch into common plantar digital nerves where they overlie the metatarsal bones, and then proper plantar nerves where they are alongside the phalanges. Here's a summary of the arterial supply of the foot. Popliteal artery giving origin to the posterior tibial, which made its way down the posterior aspect of the leg around the medial malleolus into the tarsal tunnel, where it divided into lateral plantar and medial plantar arteries. Medial plantar artery is right next to the abductor hallucis muscle. The lateral plantar artery is going to form the deep plantar arterial arch. I don't believe you'll see this in dissection. It is located quite deep, but it is on the inferior aspect of the base of the metatarsal bones. On the dorsal aspect of the foot, the blood supply is as follows. Anterior tibial artery will cross the ankle joint and become dorsalis pedis. So it's the same vessel, but different names, all relative to the ankle joint. So superior to the ankle, anterior tibial artery, inferior to the ankle, dorsalis pedis. And dorsalis pedis will continue down to the first metatarsal, where it will branch and give the arcuate artery. So what I'm trying to say here is that the dorsalis pedis will continue beyond the point at which the arcuate artery arises. Then from the arcuate artery, we have dorsal metatarsal arteries, the second, third, fourth, and fifth. Technically, the first dorsal metatarsal artery is a branch of the dorsalis pedis. And from dorsal metatarsal arteries, which are in line with the metatarsal bones, we will find that they will split at the phalanges into dorsal digital arteries. A quick review of the lymphatics of the lower extremity can be found in Moore's Clinically Oriented Anatomy, and in this image from that book we find a separation of the lymph into either a deep lymphatic return or a superficial lymphatic return. So superficial inguinal lymph nodes are involved in draining lymph from superficial nodes inferior to the umbilicus. Okay? So a lot of the superficial lymphatic drainage below the umbilicus will make its way into the superficial inguinal nodes. Popliteal nodes will drain lymph from the knee, deep leg, and the foot. Deep inguinal nodes will receive lymph from the deep thigh, as well as the superficial inguinal nodes draining into deep inguinal nodes. And the popliteal nodes will also drain into the deep inguinal nodes. So both of these systems exist on both sides of the body. They're just drawn separately for the sake of simplicity. Ultimately, the deep inguinal nodes will give rise to lymphatic trunks, which will drain into cisterna chyli. One lymphatic trunk for each lower extremity. Thank you for your attention during this narrated lecture. Please refer to the learning objectives of the lower extremity and ensure that you are able to address them using the information provided to you in this lecture. If you have any further questions, please contact either myself, Dr. Carey, or Dr. Bookstein. They will all be quite capable of addressing any of your questions on the back and extremity lectures. Thank you.